To re-invite Dr. Manisha, who is going to read the paper for the Narasimha Rao Award, correlating VEGF levels with prompt clinical regression of tubercular granulomas. Dr. Manisha.
So good morning again, and I'll just quickly run through this particular presentation of mine since we are short on time. So way back in 2014, we had this young girl who presented with this huge optic nerve head granuloma and a huge granuloma in the macular area. She had a vision of counting finger close to face. She revealed multiple enlarged mediastinal lymph nodes and a patchy infiltration in the left apical region, all suggestive of tuberculosis, with a very high Mantoux test reading. So she was put on ATT and she was also started on IVMP followed by oral steroids. She started responding well, and you see that there was a whole regression of the granuloma both on the optic nerve head and in the macular area. But to our surprise, the inflammation and the granuloma started coming back again, and we were totally lost what we were dealing with, and we assumed it to be a paradoxical worsening, and we increased the dose of the steroids. But finally, this patient, the eye became a painful blind eye with extensive neovascularization and exudative retinal detachment. And out of desperation, we started treating her with anti-VEGF injection. We started her on second-line ATT in the form of ofloxacin. And finally, this eye was lost and we had to enucleate it. And we sent the eye to JB sir at Shankar Nethralaya, Chennai, where he confirmed that very much this patient was suffering indeed from TB granuloma in the eye. Now, the question was that despite having put her on various anti-tubercular treatment and steroids, we lost this eye, and we did publish this case as a rapidly blinding posterior tubercular uveitis. But this started a few questions in our mind that this patient was responding in the chest as confirmed by the physician, but not really responding in the eye, and why was that happening? Was the delivery of the ATT drugs not adequate inside the eye? Why did she develop a painful blind eye with neovascularization, which was so acute in onset? So was it a high VEGF drive? And could we have done really something else other than just putting this patient on ATT and steroids? And that is where this entire study came up from, where we correlated the intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Now, we know that TB granuloma is the most well-recognized phenotype of intraocular tuberculosis, and we also know that these are hypoxic granulomas which are having a very high VEGF drive. And there have been reports by the PGI group that these patients develop very fast RAP lesions, which are seen as typical hemorrhages over the TB granulomas, which has now become like a distinct sign for recognizing TB granulomas. So in our study, we evaluated the intraocular VEGF-A levels and correlated it with the regression of the TB granulomas, and also we evaluated that what was the visual improvement in these patients. So 10 consecutive patients with TB granulomas were included in the study. Aqueous samples were collected at the time of giving the injection, and which were subjected to ELISA test for evaluating the VEGF-A levels. We gave intravitreal bevacizumab, that's Avastin injections, along with moxifloxacin, which was given every week till the granuloma showed a regression, along with ATT and steroids, which were not stopped. And we correlated the VEGF-A levels with the clinical regression of the granulomas. So the mean age was around 25, and 8 patients had choroidal granuloma and 2 patients had presented with optic nerve head granuloma. The mean follow-up was around 1 year, and these are the details of the VEGF-A levels, which were measured after every subsequent injection that we gave in these 10 patients. And this is how the clinical regression is. The details are all outlined. So the mean baseline VEGF-A levels was measured to be about 1000 picograms per ml in these patients, and the mean VEGF-A level at the time of last injection had dropped down to around 27. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting these intravitreal injections, and the average number of injections required were around 3. 4 patients had recovered a vision of 6.6, 2 patients had a vision of 6.18, and 4 patients had recovered a vision of less than 6 by 24. And this was probably because these patients had a regression of the granuloma with much lesser scarring that was seen with just a systemic therapy. So this is one of the patients. You again see a huge granuloma on the optic nerve head and a choroidal granuloma. 2 weeks later, she shows a beautiful regression of the choroidal granuloma, and subsequently she develops a new lesion which is diagnosed as a paradoxical worsening. She's treated with IVMP. You see there is a drastic fall of the VEGF-A levels, and this is the entire timeline of the patient. But what is important is that we are able to recover a vision of 6.6 N6 in this patient at the end of the entire treatment. And this is another patient where you see that the VEGF levels were as high as 1200 and they have dropped down to 257, and the patient has responded very well. Now, what is important for us to realize is that in TB granulomas, the VEGF-A levels are as high as 1000 and more. VEGF levels which have been reported in literature in active pulmonary TB patients is in the range of 700 to 800, and patients with AMD CNVM have the VEGF-A levels in the range of about 100 to 200. So there's a huge difference, and that is why if we were to treat these patients just with a monthly injection, probably it's not really going to bring down these high VEGF levels so fast. So this is just a cartoon depicting a typical TB granuloma where you have caseation necrosis surrounded by, I'll just take 1 minute. Surrounded by the macrophages which are harboring the TB bacilli inside, surrounded by the abnormal vessels. And what is happening in these hypoxic granulomas are that there are high VEGF-A levels which are causing this abnormal vasculature surrounding these granulomas, leading to an unequal distribution of the ATT drugs, reducing it apparently to a monotherapy and thus increasing the risk of multi-drug resistant TB. When we are giving anti-VEGFs, it is decreasing the hypoxia, avoiding the bacilli from becoming dormant, and increasing the bactericidal effect of INH. It's also normalizing the vasculature of the granuloma, thereby increasing the small molecular delivery of ATT and decreasing the risk of multi-drug resistant TB. Moxifloxacin is basically like a second-line ATT drug which we are using, but it's important to give ATT in these patients because it's only pyrazinamide which is going to be getting an access into the central caseation necrosis. So VEGF levels are measured for the first time in this particular study, and an effort was done to normalize the vasculature of the TB granulomas as quickly as possible so that the ATT drugs which are given systemically are having a much better reach inside the TB granulomas inside the eye. This was just a proof of concept study and hence a small number. And now we are very much in the process of doing a randomized study where we have already enrolled around 20 patients, and we are going to be soon coming out with the results. So we just have to keep in mind that TB granulomas are hypoxic granulomas driven by very high VEGF-A levels, and just giving ATT and steroids may not really be sufficient to regress these granulomas. So thank you once again.